This video will review the Dyspnea Approach.
For the overview, we'll do a focused anatomy and physiology review. We'll do a deep dive into a respiratory assessment, then the shortness of breath approach, and finally, we'll look at the treatments. For A&P, we're going to focus on breathing regulation. There are two sets of chemoreceptors, peripheral and central. The peripheral chemoreceptors are located in the carotid and aortic bodies, and centrally it's in the medulla. Chemoreceptor, meaning that these receptors are measuring chemicals in the blood for the peripheral and in the CSF for the central. There is a sensitivity order, meaning on the higher on the list, a smaller change makes a big difference in breathing. Lower on the list, a larger change is required to make a change in breathing. So peripheral, it's first sensitive to CO2, then pH, and then O2. Centrally, it's most sensitive to pH, then CO2, and then O2. The purpose of this A&P review is to demonstrate that the primary drive for breathing is CO2 and pH, not oxygen. There is a purpose for this though. In situations where there's severe hypoxia, it actually causes the stimulation to decrease breathing. This also happens in situations of hypercapnia, but it's so extreme that there's a built-in buffer of safety by using CO2 and pH versus using O2. Our initial priority is to determine whether this is respiratory or non-respiratory. The importance of this is simple. 1, we want to administer appropriate care, and 2, we want to prevent harm. A short example, you have a patient with sustained tachycardia, which is secondary to dehydration from nausea and vomiting. The patient's complaint, though, is shortness of breath, which increases upon exertion. The patient has a history of COPD or asthma, and this situation has caused an exacerbation of that. And so you administer albuterol, which will then further increase the heart rate and potential is to cause an arrhythmia. Remember that all medications have the potential to cause harm, aka the side effects. For the initial priority of respiratory and non-respiratory, I want to look at the most common situations that you'll see. So for respiratory, COPD, asthma, pneumonia, and non-respiratory, CHF, pulmonary edema that's non-cardiac etiology, pulmonary embolism, a low cardiac output state or a low perfusion state, and trauma. So pneumothorax, hemopneumothorax. This is just a shortened list of the most common. Ultimately, this is an infinite list. We're not going to break down each individual assessment component for time purposes. Assessment. Similar to the altermentation assessment, no one test or no one vital sign will determine your treatment modality. Instead, it's a culmination of many components of an assessment that will help you decide what to do with the patient. We'll talk about mentation, breathing, and positioning. But just know that this is the overall assessment stuff. Each one of these has its own video length worth of things that we could talk about. Mentation. First, we'll look at doorway assessment. This is really the same doorway assessment that you do on every call, just with a focus for breathing. So it's, are they tracking you when they walked in? General respiratory status, skin signs, positioning, and just subjectively, do you think the patient's in distress or not? The tracking thing is so important because if I'm short of breath and I call 911 for help, the next phase of my life is waiting for you to show up. So if they don't track you when you walk in, that's a problem. Skin signs, cool pale diaphoretic versus pink warm dry, somewhere in between. Respiratory rate, is it fast, is it slow, and positioning, tripoding, laying flat, those sort of things. Next, you need to ensure airway patency. Is the patient up talking to you in clear multi-word sentences, or are they unconscious, laying flat with sonorous respirations? Lethargic versus decompensation. I separate these two because they can have different causes. Lethargic could just be simple as took too much Ativan or maybe a heroin overdose versus decompensation which is they've been short of breath for 4 to 8 hours, and now they are unable to compensate any longer, so they're going down. For breathing, I think about it as rate, rhythm, quality, plus lung sounds. I'll read this example and then we'll go through it. Patient presented with clear, equal bilateral lung sounds in all fields with a regular rate, but tachypnea was noted with an SpO2 of 86% on room air. No accessory muscle use noted. So rate, it says it has a regular, or tachypnea. The rhythm says it's a regular rate. Quality is actually missing component here. I like to add whether this is deep, shallow, somewhere in between. And then it says no accessory muscle uses. That is a part of the quality assessment. Plus lung sound. So clear, equal, bilateral lung sound. That's a pretty complete assessment of lung sounds. Next, upper airway noises. So you hear secretions. Someone is lethargic or maybe decompensating, and they are able to swallow on command, but you listen to their larynx and there's still secretions left over, or maybe it's a child presenting with stridor. So you just carry that information forward to help you determine what's going to happen next. Lastly, positioning. Tripoding and leaning/bracing have the same effect. Essentially, the front of the chest is heavy, and when they lean forward, the anterior portion of the chest comes off, and there's easier ventilation. That's all it's providing for. Shortness breath approach. When you go on a shortness breath call, I want you to try to place your patient into one of these 4 categories: respiratory distress, respiratory extremis, respiratory failure, or respiratory arrest. So we'll look at each one of these, give a definition, and then a small example. So the first one, respiratory distress, increased work of breathing with normal vital signs, meaning that, they have an increased work of breathing, but they're able to maintain vital signs. This person's probably ambulatory. It's in terms of the scale, this is the lowest. Example would be EIB, which is exercise-induced bronchoconstriction. An older term is exercise-induced asthma. Example would be 15-year-old during PE, doesn't have their inhaler. By the time you show up, they've probably already improved. Next, respiratory extremis. I like to separate the distress and extremis because where do they fit in the distress category? So we separate this by saying that it's either distress, so somewhere in that, or extremis. This is like right on the line of failure, right on the line of decompensation. So the definition is they're at their limit of the ability to increase the work of breathing to maintain borderline vital signs. This person's breathing 34 times a minute, maybe borderline 88, 87% SpO2, not good skin signs, but they're maintaining their mentation. They can follow commands. They're able to maintain their airway. Example would be like COPD exacerbation, or maybe COPD offset by ammonia together. Next, respiratory failure. This is inadequate oxygenation or inadequate ventilation, or a combination of inadequate oxygenation and ventilation. Most recently, we've dealt with this a whole lot, but COVID pneumonia patients often fall into this respiratory failure category. This person is either like extremis, where they're breathing really fast, or maybe they start to decompensate and come down. They have probably poor skin signs. They're probably altered. Blood pressure may be high or low depending on the situation. Lastly, respiratory arrest. This means that they are not breathing. Cessation of respiration, or actually ventilation. Example of this would be like someone who has a giant stroke and it's in a brain stem, so it's just not sending signals for it to breathe. Maybe trauma with a head injury, or you got a ROSC scenario and they're not breathing after. Now that we laid the foundation for the shortness of breath approach, let's talk about the application of treatments. I want to first go a little orientation on this chart here. So on the bottom, the treatment hierarchy is talking about we're really going to apply these 4 items to any of the patients that we present. And, well, of course, we're always going to start with the least invasive and increase to the most invasive depending on the patient. So for the first one, respiratory distress, our example was the 15-year-old exercise-induced asthma, or maybe it's just asthma without the inhaler. You could maybe get away easily with just nasal cannula or maybe some albuterol, something like that. And that's all it needs to do to correct the situation. Next, respiratory extremis. This is the patient group that's most important on this table here. The reason why is this is the one where you can make the biggest difference. You can turn them around. You can prevent them from getting animated. So the example was that COPD pneumonia person where they're right on the line of decompensation. You can really turn it around and make them more towards the distress. The key, as always, is really aggressive on this patient group. Don't be afraid to assist ventilations, give positive pressure, high flow oxygen to start while you're getting set up. Respiratory failure, they're already beyond extremis. And we're not talking about patients that are like, low sugar or heroin overdose. These are like the true respiratory failure patients. They cannot be corrected pre-hospital. It's going to be a long time. It's going to be an ICU level problem. So for us, we're going to need to assist ventilations. You need to recognize this and treat them appropriately. And then last, respiratory arrest. This one's the most obvious, the easiest to treat. They are not breathing. There's nothing that you can find to reverse it. So you're going to have to provide assisted ventilations. What I want to point out here about the treatment hierarchy is all of these things really should be almost always conjoined with medications. I would say sometimes the respiratory distress on the very mild side of that, maybe just a nasal cannula or something like that will correct them. But generally speaking, we're going to be doing one of these 4 treatment hierarchy options with the medications. The medications are the key to reversing the problem that you're having here. The asthma, the problem is the bronchioles they're constricted. They're all swollen and inflamed. You give the bronchodilator to reverse that. That's the key to this. So think about it as these 4 items with the medications. For the medications, I like to separate them into 2 categories, the nebulized medications and the IV medications. For nebulized medications, we have albuterol, Xopenex, ipratropium, and epinephrine. For the purposes of this presentation, I want you to think about albuterol and Xopenex as the same thing. They're solely bronchodilators. They both work amazing. The time that I use Xopenex over albuterol is when the person is prescribed albuterol, they've been taking their inhaler or maybe even an at-home nebulizer and it hasn't been working. That's a good opportunity to use Xopenex because it works a little bit differently than albuterol, so you might have better results. Ipratropium is also a bronchodilator, but it has another function in which it dries secretions. So it has a dual functionality. My first line medication that I generally choose is Duoneb because it's albuterol plus ipratropium, so it's kind of covering all the bases. Lastly, epinephrine, not typically used for bronchodilation. This is usually more for like someone that's got stridor or anaphylaxis, something like that. For IV medications, Solu-Medrol is a steroid. Really what it's doing is it's turning off the inflammatory response, which is really turning off the immune response. This works much longer than the bronchodilators. They work great, but as soon as they wear off, it kind of returns to the previous state unless you remove the antigen, say pollen or something like that. Next, magnesium is a smooth muscle relaxant. The bronchioles are smooth muscle, and so it just dilates those bronchioles. Epinephrine works really well IV for bronchodilation. You know that from using it for anaphylaxis. And lastly, ketamine. I want to caution, this is really for the intubation patient. This is not to be given in any dose for bronchodilation in the awake patient. All right, let's takeaways. Always treat the reversible causes. You don't want to be the person that RSI'd somebody that has a sugar of 12. Make sure you do a thorough assessment, try to reverse everything you possibly can, and then treat the patient appropriately. Be aggressive with O2 delivery. This doesn't mean jumping to RSI, but give them non-breathers, BVM while you're getting set up for RSI or BiPAP or whatever you need to do. Be aggressive, do it fast, don't wait, don't delay. Next, recognize the need for assisted ventilation. If you find somebody that's altered and maybe they're not tachypnic any longer because they're decompensating, make sure you jump on that. Next, wait for the medications to take effect. Typically, the nebulized medications take at least 5 minutes Generally speaking, it's 5 to 15 minutes. Of course, there's a lot of reasons why that range is so large. Give it time to take effect before you start adding on medications. Lastly, call for help early. If you have a situation in which it's going to task you and your partner, call for the soup, call for another ambulance, call for help. It's much better to cancel them. This concludes the shortness of breath approach video. This by no means is a complete reference for shortness of breath patients. This is just laying the general framework for treatments and how to categorize these patients and how to approach them. If you have any more questions or want any more help, please contact me. This is my favorite subject. I love talking about it, and I'm here to help.